Shall we go on? So I promised this morning, and there's a young lady there who's still afraid that I said, why did you bypass me? So this morning, I talked to you about that I will, some of you were sitting in the morning this morning and I said, I'll talk about Pioglitazone and some interesting stuff. So that's really what I'm planning to do. There it is. Okay. This is the history of Pioglitazone. Takeda invented it in 1980, and I haven't seen another molecule that has been as victimized, as villainized as the glitazones. And I'll tell you some stories as we go along. But how many of you still use Pioglitazone? All of you. Okay, so if you're all using it, why this talk? Okay, so to make sure that, you know, that at 7:15 in the night, that I bring you some value, let me talk about some interesting stuff. First is, we know a lot more about Pioglitazone than 10 years ago. Right? One is the pleiotropic effects. One is the inflammation reduction. A lot of things we now attribute to GLP-1RA, you will find that they are there with Pio. For example, beneficial effects in Parkinson's disease, reduction in cerebral inflammation, improvement in cardiac, which I will talk about a lot today, and I'll talk about adipose tissue redistribution through my talk, which is very interesting. Then doesn't work directly in the pancreas, reduces pancreatic adiponectin activity in the pancreas. Muscle, we all know, I'll talk about it. But of course, its main effect is in the liver. But some interesting stuff, I have only 15 minutes, so I'll just talk various stuff. But this is the data that we generally don't talk about. One is the 47% reduction in secondary stroke. Second, reduction in reinfarction with previous myocardial infarction is 28%. 37% reduction in ACS after previous MI. And I'll talk about MASH. My own work is on MASH, so I'll talk about it. But many of us, something very interesting, that many of us think that its action is on PPAR gamma, which it is, but its action on PPAR gamma is not a direct effect. We now know it actually works through mitochondria. And the reason I'm talking about it is, the next 10 years, you're going to get a new group of drugs that work in this particular place in the mitochondria, which allows pyruvate. It serves as a gatekeeper for pyruvate to enter the mitochondria. Meaning, by slowing down the pyruvate entry into the mitochondria, it prevents the mitochondria from getting overloaded with fuel, and therefore reducing the impact. The secondary action, of course, is the epigenetic modification, including the transcription of PPAR gamma, and that is how it becomes a PPAR gamma agonist. So, some new data, right? Then, I put this talk up with this slide up because it's very, very interesting. It talks about Pioglitazone, the forgotten, cost-effective cardioprotective drug for type 2 diabetes. Fantastic. It's just a review article, right? But you recognize his name? Name is Stephen Nissen. Some of you who are older will remember what Steve Nissen did. He actually destroyed rosiglitazone by a very biased meta-analysis. So this guy actually has written, along with DeFranco, who was always a glitazone man, this particular article, so it's very interesting. So the ACT study, let me talk about two studies quickly, and then I'll go on and summarize the data. The ACT study is looking at the risk of type 2 diabetes, in a fairly large trial, and what you will see is that the hazard ratio is 0.28, a significant reduction, 72% reduction in the development of diabetes. We don't use it, but I'll tell you where we should probably be using it. Right? The second is a proactive study, and this looked at macrovascular events, 5,238 patients with established cardiovascular disease, right? And let me show this to you in a simpler fashion. This is a redrawn picture, but what you will see is, this is a Kaplan-Meier curve. The HR was 0.84 versus placebo, p-value of 0.02 in preventing second MI. That is MACE, this is second MI, and this is overall mortality. So clearly, CV protective. Then, this is the IRIS study that looks at it after a stroke, right? Look at the data, very interesting. The primary outcome, HR is 0.76, upper limit of confidence interval is 0.93, superior, clearly superior. This is a meta-analysis looking at all the outcomes. This is MACE, myocardial infarction, stroke. We don't talk about stroke, but remember even GLP-1 RAs, remember dulaglutide? Reduced stroke a lot. Similar. But clearly there's a signal for heart failure in all these trials. There's a signal for heart failure, class 3 and above, do not use it, so we'll talk about it. All-cause mortality in some of these studies was lower, but not really much. But is there an increased risk of fracture? Absolutely. Older patients, in some of the meta-analysis, a greater amount in women than in men, but definitely there. Cancer. Overall reduction in cancer, but there is a bladder cancer risk. Let me quantitate it for you. If you use 15 milligrams of pioglitazone, 40-gram cumulative dose, which is 2,666 days, 7 years. At higher doses, higher things. But between 50 and 40 and intermediate, but certainly above 40 grams, that is 7 years of usage, that's the upper limit, that you will see a clear increase in bladder CA. This is after control for smoking. Lower in Asians, higher in Caucasians and Europeans. This is the data that you should be aware of. Does cause edema, does cause weight gain. At the 45-gram dose, about 3.2 in most studies. We don't even use that data that much. But the interesting thing that you should remember is, just like SGLT2 inhibitors, Dr. Makkar is not here, how do you know an SGLT2 inhibitor acts? How do you know it's producing cardiovascular effects? You know it because the hematocrit goes up. Because it works through HIF2. Hypoxia-inducing factor, therefore the hematocrit will go up. Similarly, if the weight doesn't go up, your TZD is not working, except when you combine it with an SGLT2 inhibitor. So just as a summary of the known effects, just remember, heart disease, prevents stroke, prevents diabetes, improves NAFLD, increases bladder cancer, reduces lung cancer, reduces breast cancer, reduces colon cancer. So this is the summary of what we know. Let me move on. Very interesting is that a lot more data we have understood about what it does in the heart, including improvement in diastolic dysfunction that some studies have shown. But I thought one interesting piece was this, that it reduces the risk of atrial fibrillation. It's interesting that we don't use it, but a 30% risk of developing an AFib, a reduced risk of a new onset AFib, and a reduction in recurrence of AFib. Something we don't talk about, but interesting data. A lot of interesting data on this. I just picked up one piece of information for us to understand. The guidelines have continued to use it as a secondary therapy, use in MASLD, as well as in this thing. But let's think about something else, right? This is our study on MASLD. Combining a glitazone with SGLT2 inhibitor reduced FIB-4 scores to a greater amount. And interestingly, some of these patients were on 7.5 milligrams of glitazones. But there was a significant reduction in the FIB-4 score. We will have an updated on this. This is in the IJCMD that was published in April 2025. How does it work? Both of them work very well together. This is like a mate for each other kind of thing. They balance out each other, they do different things, and therefore works beautifully. But here is some very interesting data that in early nephropathy, the combination seems to work. Interestingly, Georgie is not here, but this morning I was planning to tell him that in ESRD, patients who have end-stage renal disease, using pioglitazone can actually shift the, he was talking about, remember, I don't know how many of you were there when he was talking about a fat redistribution. that it has been found to be safe in ESRD in that particular group. This is the combination, this is the Korean meta-analysis, reduction together in 4P MACE, reduction in cardiovascular death, reduction in non-fatal MI, non-fatal ischemic stroke. But interestingly, the combination does not have an increased risk for heart failure hospitalization. So the SGLT2 probably counteracts it, and therefore they work very, very well together. Right. This is the outcomes. I just put it up what I could find. Now, moving on, my last bit, I have 4 minutes. So this is how I think about obesity. I know you hear a lot of it. I think about this part. Inappropriate weight, inappropriate fat, inappropriate distribution, inappropriate function, leading to inappropriate outcomes. These could be biomechanical, metabolic, and psychological. The inappropriate weight causes a biomechanical outcome, but all the others are due to inappropriate fat, inappropriate distribution, inappropriate function. But we also know that there are a bunch of people who may not be obese with a BMI that is very high, but can have altered fat distribution and function. That's most of us Indians, right? Metabolically unhealthy fat. And in fact, in the ICMR INDIAB study, this is the group, the metabolically non-obese, obese is what they have used. This is a large group, and my name is somewhere here. So you'll find that this is the percentage of patients. And interestingly, in this group, the risk of diabetes is high, the risk of CAD is high, and the risk of CKD is also high. Now, in this group, you may not have the biomechanical outcome, but you still have the method that we can use in this particular group, right? Now, very interestingly, when you use glitazones, older study, what happens is, this is a higher dose of glitazone, by the way. Can you see what has happened? When you give it, just like this morning when I talk about GIP, there is a redistribution of fat, a strengthening of the subcutaneous fat. Can you see that subcutaneous fat area has gone up? There's a reduction in visceral fat. How does it work? Very interesting metabolomic studies that show that it increases the membrane lipid, but it reduces the arachidonic acid content of the membrane lipids. Therefore, all it does is it strengthens the fat, preventing fat from becoming ectopic, which is exactly what I said this morning that GIP does, GLP-1 RAs do. So, this is the effect of TZD on fat. Can you see this part? Subcutaneous fat increases, visceral fat area comes down, the visceral to subcutaneous fat also comes down. So, have we forgotten this drug? I think so. Should we start using it, this thing? So, let us summarize the way we should use it. Avoid established heart failure, definitely avoid. Older women with an increased risk of fall, definitely avoid. Increased risk of bladder cancer, somebody who's a chain smoker for many, many years, do not use it. I use NT-proBNPs in my practice. Again, Dr. Makkar has left, but he talked about heart failure. NT-proBNPs is something I measure. If I have a very high NT-proBNP, I will not use it. One of the ways that this works is it creates new small fat cells instead of older fat cells being hypertrophied. Now, where should we consider it? MASLD, along with an SGLT2 inhibitor. CV protection in atrial fibrillation. If you can't use a GLP-1 RA, consider triazolidinedione has a fantastic data. Atrial fibrillation, stroke protection. I have started using the triglyceride glucose index as a good way of saying, is this significant insulin resistance that I can use? You don't have to do HOMA, IR, nothing. Log 10 triglyceride into glucose by 2. Greater than 8, definitely. What about lower doses? Most of the data that we see are at higher doses, 15, above 30 milligrams. We need to look at lower Indian data on this. Where we also need data is, should we start using in these people who are metabolically unhealthy, non-obese, the mono guys, right? Or should we also start targeting it in diabetics who are of this kind of phenotype? We need more data on this. But I think the drug is not dead. We think we should start using it a lot more, and it makes sense. So this is how it works. And I just thought I'd put this up. So do you think it's time to reuse it? I think so. or maybe we should get a little more experience. Thank you so much. I'm so happy to see so many of you this time.
Thank you.